Well, the slides are coming up. First of all, thank you very much for inviting me. It's always great fun to come to these meetings. I probably speak far too much. I get invited back, so presumably that's acceptable. Let's see if I can remember how to work this. Okay, so regardless of the title, of course I've changed the title because the title was written before I had a conversation with Patty about what she wanted me to talk about. So I'm really going to speak about the last 25 plus years of experience in the UK. Now, I think it is important. The UK is very different. We're talking about population screening with a planned program. You're clearly talking about individual screening. We have central funding. We have a central process of QA. You're working on cost per case. There is clearly a completely different view about litigation. I don't know whether litigation is more prevalent or not, but there's a completely different view about litigation. So we're coming from very different backgrounds, but I think there are lessons to be learned. We have, and always have had, like most of the European programs, because we are a program, had embedded quality assurance. So as soon as we started, we had a quality assurance program. So that works that each region and the Celtic nations, they're still Celtic nations, they haven't yet gone independent, as far as we know. I haven't looked at the news this week. So that the whole process was built around QA, and it's built around regions. So each region has its own QA system. That means there's admin staff, there's someone in charge. Each of the professional groups, that's the very extended professional groups, feed into that QA process. Parallel to that, there was a public health and evaluation element, which I've been very lucky enough to be involved in right the way through. And right at the beginning, we set standards. And the Europeans followed, and we set a minimum standard, and we set an achievable standard. We audited that, and every 3 or 4 years, it's now slightly more frequent, we saw and measured how we were doing against that standard, and we raised the bar because we got better, and we kept on raising the bar. Now, when we first set it up, I don't think there was any very much science. Pat Forrest said, well, it should be about like that, and Eric Roebuck said, yeah, it's about okay, so we'll put it like that. But when we started measuring ourselves, we looked at ourselves, and then we went back, the most important thing we did in terms of cancer detection was we actually realized that we needed some form of standard. So Roger Blanks and Sue Moss and I sat down, I provided the clinical bit, they provided the noise and the statistics, and we worked out with Steve Duffy what we should be expected to find. Now we based that on the Swedish 2 counties, so we said, right, well, we're supposed to reduce a 20% fatality and reduction. Okay, that was a bit naive, I agree, but it was 20 years ago. So what would we do if we were performing if our population performing in the same way as the Swedish 2 counties trial? And we produced an age standardized figure. And we have used that all the way through. So everybody has always been measured against that age standardized figure. And that's really important when you've got lots of different age bands, you've got lots of other groups. So we've got all these groups, we've moved these things grouped. The professional reps and the admin at each individual level are there to help monitor and coordinate the regional program, and they feed back nationally into new standards. So it's a whole cycle of change. The most important thing about this is that the professional reps who are increasingly trained for this process, we didn't do any sort of training originally. I come from the generation, it's see one, do one, kill someone at 3 o'clock in the morning. No, that's probably not true. But that sort of thing, educational methodology didn't exist when I was a baby. But peer support is really important, and it's what we do for these professional reps provide this peer support, and that I think has been the real advantage about our process. So, this is the so-called modern quality assurance and quality improvement system. You identify the good people, you identify the good systems, and then you move everything along by changing the whole process. Well, that's supposed to be the modern way forward in 2011. 1998, God, I'm old, aren't I? I forgotten how old some of these studies were. We showed that reading practice was the major determinant of performance, both cancer detection and recall rate. And we use double reading, we use some form of consensus or arbitration process, and actually it's that process that enables us to find more cancers, and also it has an effect on recall rate. And that's the important bit. Look at those effects on recall rate. They don't seem very much in absolute terms, but we've got a very low recall rate. But the difference between 3.4 and 4 is an awful lot of women when you're screening 2.5 million a year. And we'll come back to that because I think that's how you affect recall rate. I got involved in the Cadet 2 study, and it might not work in the States, but at least in the UK, in our practice, actually, single reading with CAD in terms of cancer detection was as good as double reading, but the recall rate went up because all the issues around consensus, discussion, teamwork to pull the recall rate is lost in this sort of trial. All right. So, the traditional system, this is what I call the stick. You beat up the underperformers. You identify them and beat them up. Now, the given wisdom for this is that you only take a little bit of shift by removing the bottom. But actually, this is all based on the assumption that we're working on a bell-shaped curve, and we've seen on a series of slides today, and this is my example from Performs, actually there's not a bell-shaped curve. There's a long tail of underperformance or less well performance at the bottom, so that if you can knock off the ones at the bottom, which can be some quite big units and heavy units, the whole system moves up a lot better. But actually it's a repeating and cyclical process. If you always keep knocking off the bottoms, getting them better, you move the whole thing sequentially along each time round. So you've got to be able to identify, I believe, the low performers. Now, actually, I think the modern system is good because I think probably in the UK, there are about 20 or 30 superb radiologists. The rest of us are average, but there are 20 or 30 really superb radiologists. If we could work out who they were and what they did, we would all improve. Now, I'm not convinced that the superb radiologists are necessarily the ones that sit up and stand up at meetings like me and teach. Some of them are out in the periphery, but if we can work out exactly who those really good ones are, that's where we do. But you've got to identify the poor performers because they're probably doing harm to women. So, how do you move from the stick to the carrot? And I'm going to use an example from the surgeons because the surgeons are very into sticks. And I spend a lot of time with the surgeons and the Associated Breast Surgeons at BASO on annual data collection. It is now 17 years since we started collecting the surgical data, and we've got 17 different colour booklets. Thank God Public Health England, which is the new monitoring body, has decided that we're not going to publish this booklet anymore, so we haven't got to find the 19th colour. So the process was annual data collection. We collect it all. Took the first few years to persuade the surgeons it was their data and not my data, but once we persuaded it was their data, things started improving. We collate that on a national and regional basis. We identify the underperformers, and we feed it back. Now, this is surgeons, remember, so feedback when we started was a little bit interesting. And we put it up like this, and there were graphs like this that showed, and all the graphs showed, that there was always someone on the same 2 or 3 people, year in, year out, at one end of the table, and nothing changed. And being surgeons, we tried the sort of the annual feedback, and then it became annual feedback by public humiliation, so that the individual surgeons had to stand up in public at the annual meeting and say why were they different. The mastectomy rate, it was always patient choice. No question about it, it was patient choice. And it's true, it was patient choice. I certainly remember one in the West Midlands where I came from. Every woman had a mastectomy. Every woman had choice. Every woman saw the patient group. But of course, the patient group and the patient representatives all had mastectomies. And they all absolutely loved the surgeon until he retired. But as soon as he retired, they reverted to the mean. So it is about population. So public humiliation by feedback might work for surgeons, but not very well. And it clearly wasn't affecting. So change the feedback. Once you change the feedback methodology, it should enable you, the feedback system should then enable you to analyze the performance. And once you sit down and analyze the performance with the individual surgeons and look at their individual practice, show them where they came. Not on just, you've got a very high mastectomy rate, you're a bad boy. You show them and talk about where it is, then you can motivate for change. Does it work? Actually, it does, surprisingly. We quite like these tables. This is a surgical table, and what we've got is the overall mastectomy rate over a 3-year period, because we've got to demonstrate that this is stable. This is not, oh, it's just 1 year, I've just been difficult this year, I had a bad year, it was only 2 cases. Doesn't work. 3 years makes a nice round numbers. And then 3-year breast screening conservation, so started off with a conserving surgery, but for reasons best known to themselves, lots of potential reasons, they moved on to a mastectomy. First, second, third operation, sometimes people have 4 operations to get there. So you then plot out the failure of conservation against the mastectomy rate. You put the means on the graphs, and you end up with 4 boxes. And you end up with high mastectomy rate, low conversion rate. Obviously, that's where you would want everyone to be, I think. Low overall mastectomy rate, low conversion rate, even better to be in there. Then high and high, and clearly if you're in the top corner, you want to try and move people down. But perhaps that's right, perhaps those people up there are very keen on conservation, desperately keen on conservation, but they have a high margin policy. They have a margin policy that doesn't fit. So, now, this worked in Cambridge. Cambridge had a very, very aggressive margin policy. We had and still do have a very, very low local recurrence rate. But we looked at this, we sat down with the surgeons, we talked about it, and over a period of time, we pulled this back. By changing our margins, by constantly talking about the MDT, is this right? But it doesn't happen overnight. Because what you do today doesn't necessarily appear in the figures, potentially for 18 months. Because it's a year's period. If you're using 3 years means, you can get better 1 year, but that might be a chance. You have to get a process. So none of the results of this process are going to appear tomorrow or the day after tomorrow. It'll be next year, or more likely the year after next, before you see the results of these interventions, unless you've got something that makes a major change. And we're way beyond the opportunities for major change. We had those 20 years ago. So, radiology, which is what we're going to talk about now, is much more, I think it's much harder because we've done all the big things. And we're all actually performing pretty well in a very, very tight little area. So we still have annual data collection, we national and regional data collector, we do identify underperformers, but the first question we ask ourselves, is that underperformance a real problem? In other words, is it related to small numbers? Is it a one-off? Is it clinically important? And that's key, because there is no point in going in and them saying, oh, it's just statistical chance. Because you're absolutely screwed if they turn around and say, oh, it's statistical chance. Feedback. If there's a serious problem, the QA team will then actually visit. So they provide a mentoring service, and the feedback is designed to help both the mentor and the local team to analyze their practice and say, well, I'm arriving this box on the table. These are the sort of interventions that might work, have worked in the past. I've left this in because I think we have talked about it, but it is really, really important that volume and underlying prevalence of cancer makes an enormous difference. Again, this is Cambridge. We use SDR, which is a standardized detection ratio. We started off with a 1. We're now expected to get an SDR of 1.4. And you can see on the SDR total, that's all women, 50 to 70. This is in blue, the annual performance, and then in red, the cumulative 3-year performance, and this is how we present all our data. We screen 18,000 women a year. We are a pretty small program in Cambridge compared to everything else, and we expect to find 58 cancers, and you can see it's pretty stable. So what we do year on year is pretty stable. However, if you look at small cancers, first screen, okay, it says essentially it is only 48 to 50. There are only 4,000 women. We're expected to get 7 cancers. Okay? In 2001, we found 4 cancers. We're way under. In 2009, 2010, we found 13 cancers, and we were way over. But even with the 3 years, that small group of women, look at the confidence intervals based on the 3-year data. You cannot make any decision about intervention or performance when you're talking about numbers this small. You've got to get bigger numbers, some way, somehow. So, we've already seen data earlier on yesterday about how we were going, how we performed, and I've taken this off from the AGA paper ages and ages ago, and this is never going to work over the other side, but we've got groups up here with very low recall rates, virtually the same recall rates, a low positive predictive value, a high positive predictive value, and these are the cancer detection rates, 4, 5, and 6. So clearly, someone in here needs to do something, and someone up here is probably really brilliant. So if it was me, I'd love to be up here. Ideally, I want to be out there. So someone here basically needs to increase their recall rate and pull themselves in this direction. And we've got good evidence that for teams, if you, this individual team, we've suggested and we talked to them about pulling their recall rate, and we pulled them out over here. Down here, sorry. So, rephrase. So, out here, there's a problem with recall rate. We've got low recall, low cancer detection. We've intervened with this program, and we've got good evidence, which we've seen elsewhere, that if you intervene, increase the recall rate, this program ends up over here. Over a 4-year period, they steadily move over in this direction. This group down here, with a highest recall, well, I think it's the highest recall rate, but a pretty low cancer detection rate, they need to be taught how to read the films. This group out here, and of course, your groups are all out here, this group out here at the far end needs to do something about recall. So you can just tell them not to recall anymore because that's too bad, but actually what you do is you go back in, you find out how they're reading, and this group, again, I know very well, we helped them. They were recalling on, well, anyone who fancies to bring it back, we'll bring it back. So we said, first of all, we went in and said, well, let's pull up 100 of all the recalls that didn't turn out to be cancer. And they all looked at them and said, God, why did we recall that? I've been doing an awful lot of assessment, completely wasted it. So then you say, right, okay, those are the things you're not recalling. So let's sit down as a group, and rather than recall everything you want to recall, you discuss twice a week. And do you really want to recall? Now, that works quite well, but if you have a dominant member of the team who is very enthusiastic on recall, obviously that dominant member of the team, everyone bows down to him or her, and it doesn't change. So if that's a problem, the mentor goes in. And we actually went in with a couple of mentors from elsewhere in the region and helped them twice a week for 2 or 3 weeks. We wouldn't recall that. Why wouldn't you discuss the things to recall? And the cancer detection rate stayed the same, actually went up slightly, and the recall rate comes down. So it's about using these tools. I'm sorry to say that using specificity and sensitivity for most radiologists in the UK is straight over their head. It's statistics. Most radiologists fall asleep in statistics. I'm sorry, Marielle, but it's true. Most of us fall asleep in lectures about statistics, even if we went to those lectures at medical school. Because when I was at medical school, you didn't have to go to lectures. You were expected to be on the sports field. So analysis of first reader performance is the thing we've now been moving towards, because we've been very good at teams, we've improved teams, but teams can hide good and poor performance. So we've been looking at graphical ways, and this is something that I've been doing with Jill Lawrence and the team in the West Midlands to provide this graphical feedback. The idea of producing graphical feedback is to give an easy way for people to look at their data and say, this is how I would want to change it. This is where I appear on the thing. And then similarly, if you've got a team, can you look at this and say, well, actually, Matthew, you really ought not to be reading with Peter because you read in the same way. If at all possible, you should be reading with Ruchi, and Ruchi should be reading with someone else. So you don't mix readers with the same performance. You complement readers. Now, that's very easy when you've got double reading and you've got teams. But there's no reason, I don't believe there is no reason in the current ability to move films around why you can't set up teams. If you're going to look at individual readers, and in the current climate in the UK, if there's data out there available about audit, that will eventually become public. So you've got to ensure that whatever you do becomes stable and robust, so it's defendable. So Roger and Verita have worked out, very interestingly, that it has to be about 3,000 films for first reader data, which fits very nicely with what we've heard before. And this is what we do. We plot recall rate against cancer detection rate. Now actually, we've plotted recall rate against first reader miss. We've plotted recall rate against first reader miss plus interval cancers. And that first reader miss is an exact mirror of this graph. But clearly it has far less stability because the numbers of misses of first read, of which inevitably there must be some misses of first read, otherwise there wouldn't be any point in having double reading, and the interval cancers are just not stable. And you end up with something that you've done with the surgeons, which is a box. It's divided into 4, and they're good corners and bad corners. You can put standard deviation rings around this, and this is a regional ring, but local data. And it's quite clear that you've got areas, we've got high recall rate with high cancer detection. Well, clearly you want to try and reduce the recall rate. But you also have someone who is very non-sensitive, very non-specific. So you need to potentially intervene with that individual or make sure that that individual reads potentially with the person at the far end who has a very high sensitivity and very high recall rate. You put them together and in theory you should get somewhere near the mean. And actually it works, because we've demonstrated it works. Oh, sorry. And so you can then plug in potential actions onto the box. So you're not just told, you're here. Oh, fine, I'm there. What do I do about it? You actually have a model of intervention and suggestions of how you work, how you change to put into that graph. And you can do that to teams or do that to individuals. Now, clearly, this is a very UK-centric system because you can change the way you double read, etc. So, how does the UK team system work? The key message is that we do work in teams and we do offer double reading. That's really important for the way we practice. We have peer review And that peer review increasingly involves mentoring, is built into that QA process, so we don't just hand bits of information back and ignore it. And everybody gets into that peer review and mentoring. Over a 20-year period, many of the radiologists in practice in a region will get involved in that process. And you move into that process, and mentoring works because we're offering mentoring around the rest of the hospital and the rest of the trust. We train the QA teams. We didn't used to, but we now train them. And we have certainly changed the way we offer feedback to facilitate this analysis and to facilitate intervention. So it's not just a desperate graph, a pie chart, some form of statistical graph that shows you're this dot. We actually try and make it so that it facilitates the interventional process. And we believe that that improves practice. Thank you very much.